Hi everyone, my name is Maeve McMahon. I'm the community manager here at Agents of Change. I am a licensed social worker and today I'm going to be conducting this CE on conducting risk and safety assessments. A little bit about me. I'm from Chicago, but I currently live in Cleveland, Ohio. I received my master's degree from Case Western University, where I specialized in children, youth, and families. And now I work in a hospital as a pediatric behavioral health social worker. So in my current position, I specialize in mood disorders. Specifically, I have teen patients. I occasionally will see kids younger than that, but typically the focus is on 12 to 18-year-olds with a history of suicidal ideation and non-suicidal self-injury disorder. So I conduct a lot of risk and safety assessments on a daily basis in my position, and we will talk a little bit about that and use some examples throughout this CE today. I am passionate about bringing mental health care services to inner city communities in the Cleveland area as well, and making sure that everyone has access to the mental health care that they deserve. So today, a little bit about the agenda, what we're going to go over. We will learn about the prevalence of adolescent depression and why it is important to complete risk and safety assessments. You will see that the prevalence of adolescent depression has drastically increased in the recent years. So as social workers and mental health professionals, it's critical that everyone has an understanding on how to complete a risk and safety assessment. And because of having to know how to complete a risk and safety assessment, you will need to know how to use the tools to evaluate levels of risk in clients with depression. So there's two specific tools that we will get into today. And then following that, we will learn treatment steps to adequately treat patients with depression that are diagnosed following their evaluation. So today's learning objectives, we have 5. The first is identify clients in need of safety and risk assessments. So when a client walks into your office, how do you know that that is a client that needs to be evaluated, needs to have a safety and risk assessment done for their safety? The second is developing an effective safety plan through communication with the clients. So there are some specific tools that we will discuss today in our session about how to best conduct that safety assessment with patients and how to get the most information out of them and communicate with them best in this very vulnerable time. The third is understanding why adolescents and teens are at risk for suicidal behavior or ideation. So there are some risk factors that put teens specifically at risk for suicidal behavior or ideation that might not be as applicable to other demographics. Number 4, utilize the CSSRS in safety and risk assessments. So we will go into exactly what the CSSRS is, but this is an essential tool to use when meeting with any patient who has any kind of self-harm or suicidal ideation behavior. The 5th is identify risk and protective factors the client has for suicide or self-harm. So again, we will get a little bit further into this as the session goes on, but one of the most critical things that we must do with any patient, specifically teen patients in this situation that have any kind of suicidal or self-harm thoughts, we need to identify risk factors and protective factors so that them and their caregivers are aware of these and can either implement the risk factors or implement the protective factors, and take away the risk factors in the home. Here is a little bit about the information on my journey with safety and risk assessments. So from 2019 to 2022, I was in my master's program studying children, youth, and families while getting my master's. So when I was in this program, I made sure to take a lot of classes focusing on teens, focusing on adolescents, and focusing on family structures so that I would be able to reach my goal of being able to work with teens and work with teens in these vulnerable situations. So in my time there, I did a lot of work with younger kids, with teenagers and made sure to focus my classes around any information that would help me with high-risk patients. While I was getting my master's, I was also working full-time, and I worked at a nonprofit with homeless and missing teens that were struggling with mood disorders. In this job, I was able to gain a lot of experience on crisis intervention, especially crisis intervention with these teens that were diagnosed with mood disorders. So being able to balance their safety with their mental health while also trying to manage their safety and just day-to-day life of finding somewhere to live, making sure they have food to put on the table, and that kind of thing. So that really gave me a jump start into being able to conduct these risk and safety assessments. Starting in 2022, I started working in the hospital that I'm currently at in the pediatric depression clinic. So, like I said, I primarily work with patients that have mood disorders. And unfortunately, due to the climb in pediatric depression patients recently, most of the patients in the mood disorder diagnosis also have the depression diagnosis. And starting in 2022, I also started working with Agents of Change. And here I've found a lot of joy in supporting students of Agents of Change and also creating learning content for the students of Agents of Change. All of this experience has given me really great insight on how to deal with these stressful situations, and dealing with any kind of safety concern in any kid, in my case it would be teenagers, can be a very stressful situation. So I think that this CE, breaking down exactly how to do it, giving tips for how to make it the most effective experience possible for the client, is going to be very helpful. So, as I've already mentioned multiple times, teen depression is very prevalent in the United States. So today we're going to start off with just a quick question to kind of get our bearings about what percentage of teenagers suffer from depression in the United States on a yearly basis. 1, 5%, 2, 12%, 3, 17%, or 4, 45%. And I will give you guys a moment to kind of think about that and get your answer in. Okay, so the correct answer is 17%. There is an estimated 4.1 million adolescents aged 12 to 17 in the United States that have had at least one major depressive episode. And this number represented 17% of the US population aged 12 to 17. So this data specifically is from 2020, and we know that in 2020 there was a drastic change in everybody's life with COVID, and that definitely increased the amount of people and teens that were struggling with a major depressive episode. So I really like this graph because not only does it go into overall how many people have been struggling, how many adolescents have struggled with a major depressive episode, but it also goes into more details about sex, age, and ethnicity. So you can see here that females are more affected than males with major depressive disorder, and females are actually at 25.2% of females that are adolescents have struggled with a major depressive episode. Males are also at 9.2%. And then here we get into ages. So ages 12 to 13, we're at 11.2%. Ages 14 to 15, we're at 18.2%. And 16 to 17, we're at 21.9%. So that, unfortunately, is a steady increase on how many children are developing depression as they get older. So there may be some signs when they're a little bit younger, start to hit 13, 14, and that number drastically increases. So from 12 to 13 to then 16 to 17, that number almost doubles, unfortunately. This is why it's important for mental health care professionals to be able to treat depression adequately, so that if there's symptoms that start to show when they are 12 or 13, that can really be targeted at that point. So then with 16 and 17-year-olds, the number can come down because there aren't as many kids going through all of their teen years with depression. I will say that in my experience with the populations that I've seen, the kids are starting to get younger and younger with their ages. So if I had to make a prediction, I would guess that these younger ages, unfortunately, I would guess that the percentage is beginning to increase a little bit. And that's due to a number of different things that we will talk about later on in the CE in terms of risk factors and different things that they can be exposed to that now they get exposed to at a younger age. Here you can see that the race and ethnicity ratings for depression are not too different, with Hispanic 15.7%, white 18.7%, Black 12.9%, and Asian 13.9%. I will say that there can be things that are not taken account in certain studies that give these percentages, such as mental health care is unfortunately not available in some communities as much as other communities. That is also something that we will talk a little bit about today, making sure that this mental health care is available to anyone who needs it. And that is one of the things that I'm very passionate about in my practice as a mental health care professional, as a social worker, making sure that we are acknowledging all communities, all demographics that need any kind of treatment. In my case, it's major depressive disorder, it's suicidal ideation, it's self-harm, and not just making sure that this care is given to people who can afford it or people who have as easy access to it as possible. So here's some information about what the research says about depression in teens. So among children aged 13 to 17 years in 2016, having another mental health disorder was most common in children with depression. So having two diagnoses is what we call comorbidities, and that can be depression and any other kind of mental health disorder, or it can be any two other kinds of mental health disorders. Today, we're going to specifically be talking about depression. About 3 in 4 children with depression also have anxiety, so that's 73.8%. And then almost 1 in 2 had behavior problems, so 47.2%. It is very important when treating any kind of client that has a comorbidity, including depression, to also take into account that other diagnosis. So that other diagnosis can often have symptoms that fall over into the depression. For example, what we know about depression is that it's really important to keep a routine. It's important to get interactions with loved ones, with friends, with family. It's really important to go to school every day and get that interaction with other people to kind of fulfill your day, to give meaning to your day. Unfortunately, with people who have anxiety, they then have that aspect of anxiety that comes in that makes it difficult for them to do the things that would help their depression. So they might be very anxious about going and spending time with people for a variety of reasons, whatever their anxiety might be about that situation. So then, when treating the depression and going through the benefits, the things that you can do to help improve the depression, you also have to take into account that other disorder. In this example, we're talking about anxiety. So you would have to work through that anxiety about the social interactions, the going to school, the keeping that routine, before you can just give a kid something to do. You have to make sure it's actually something that's attainable for them. And oftentimes these other diagnoses make it not as attainable for them. Another diagnosis that I see frequently with depression is ADHD. And ADHD is something very important to keep in mind, especially with depression, especially with self-harm, suicidal ideation, because some children that have an ADHD diagnosis are very impulsive. So this is something to keep in mind when treating people with depression. Like I said, this could just add another risk factor to their treatment. So trying to be aware of any other diagnosis. So as I mentioned previously, the ever having been diagnosed with either anxiety or depression numbers have gone up drastically, and this data is from a little bit ago, but the data that will probably come out after COVID, I'm sure the numbers will have continued to rise. So ever having been diagnosed with either anxiety or depression among children aged 6 to 17 years increased from 5.4% in 2003 to 8% in 2007 and to 8.4% in 2011 to 2012. Like I said, these numbers are a little bit old, and there are some factors that will drastically play into these numbers, and unfortunately, my prediction would be raise those numbers. Like I said, COVID is going to be a big one. Another one that we will be getting into in a little bit is social media usage. Social media, unfortunately, plays a large role in mental health for kids. There's a lot of good that social media can do, but there's also a lot of harm that social media can do, and that will be reflected in these depression numbers in years to come. So here's what the research says. Suicide is a leading cause of death in the United States, with 45,979 deaths in 2020. This is about 1 death in every 11 minutes, which is extremely alarming to think about. In 2020, suicide was among the top 9 leading causes of death for people ages 10 to 64. Suicide was the second leading cause of death for people ages 10 to 14 and 25 to 34. So I mentioned a little bit earlier that the numbers for adolescent depression are getting younger and younger. As we saw in that graph, the older teens, 15 to 17, was a little bit higher, but as the years go on, the amount of younger children, younger adolescents who are being affected by suicide, unfortunately, is rising. So second leading cause of death for people ages 10 to 14, that is a drastic amount. So why are teens at risk for developing suicidal behaviors or ideation? As I mentioned before, we're going to get into a little bit about why are teens so at risk. Yes, this is a diagnosis that affects everyone. No one is immune to it, but there are some things that specifically make teenagers aware, or I'm sorry, not aware, make teenagers at risk for these suicidal behaviors or ideation or self-harm. So the first, teenagers spend a significant amount of time on their phones. When they're on these phones, social media creates a higher risk of cyberbullying and negative interactions. I would also add to that social media gives a place for teens to be able to compare themselves to others, to analyze other people's lives, make assumptions about other people's lives, and then compare them to their own. There are definitely some applications that are higher risk than others for teens and for children. I would say the top 3 that I have witnessed become problematic are Snapchat, Instagram, and TikTok. Snapchat is probably where we will see a lot of this cyberbullying and negative interactions happen. We know that anything we put out onto the internet is permanently out there, regardless of if there is this idea that it disappears. But children will often use Snapchat as a place to cyberbully because they feel nothing can be traced back to them. So they feel as if they send a negative message to a peer, that peer sees it, and the person who sent it can just never think about it again because it's disappeared. They don't have to think about it. There's nothing that proves that they are the person that sent it. But whoever's on the receiving end of that it doesn't disappear from their mind. Words have a lot of power, especially with teens, especially teens who are at vulnerable times in their lives. And Snapchat gives that opportunity to really use that in a negative way. Instagram is where there is probably a lot of comparison happening. So I like to talk about with clients how people make their Instagram their highlight reel. They're not posting pictures of when they're having an awful day. They're not posting pictures of when they don't feel great about themselves. They're not posting pictures about when they fail a test or when they get into a fight with one of their siblings or one of their friends. So when you follow other people on Instagram, you're seeing their highlight reel, but you're not seeing, and that's what you're comparing your life to, their highlight reel. This will also be where a lot of body image comparison comes up with teens. They see other people with all of these great angles and photoshopping and lighting and posing and all of this, and then they compare their bodies to those people who are on Instagram. TikTok is something that has come around in recent years and has definitely impacted mental health in teens. For one, I would say that with a lot of teens, it's just addicting. You sit there and you scroll and you scroll and you scroll, and all of a sudden hours have gone by and all you've done is look at your phone screen, which is not great for your mental health. TikTok is also interesting because it's an app where you see content from everyone. So your homepage on TikTok is just curated of anything on the app. It's not just people you follow. So you can't really provide that safe space for yourself by only following people that you want to see content from, because when you go to your homepage and scroll, you will see any content, and you never know what's going to be triggering. You never know what's going to see something and trigger a mental health issue in your mind, trigger a negative thought, trigger something. And I would say TikTok is definitely a place where this often happens with teens. Teenagers also can get a lot of positives out of social media. So here I'm highlighting a lot of the negatives. I have had a lot of teens who say they find camaraderie in social media. They find it comforting to see content of people who have gone through similar situations of them. It makes them feel a little bit better. So, of course, anything in moderation is okay. But when teens are almost addicted to their phones and spending such a significant amount of time on their phone, that's when it becomes concerning. The next risk factor for teens is that their bodies are changing, and negative body image often begins at this time. So teens are going through puberty, their bodies are changing for both girls and boys. And there's a lot of thoughts going on. Social media definitely plays into what they feel like they should look like. They want to look like others, they want to fit in. They don't know what's going on with their body, and there's a lot of hormones going on while their bodies are changing that bring up these emotions. So the bodies changing are definitely a big risk factor for when this negative body image can begin. Pressures from school, sports, friends, or family often begins to feel overwhelming as well. School and sports really start to ramp up around the middle school, high school age. Things get more competitive. Schoolwork gets harder, and there's more pressure put on kids, whether it's realized or not, by the parents, by the teachers, by their friends, to succeed in school and sports. And they want to do the best that they can to not disappoint other people. And oftentimes this pressure begins to build and build and build. And that's when we start to see some of those depression behaviors develop a little bit. It's also a lot of pressure from family. Parents have great intentions. They want their kids to be successful. They want their kids to do the best that they can. But sometimes these pressures become very overwhelming for teens, and they don't know how to put up a boundary with these family members or friends and say, hey, I'm trying my best. I can't give you anything else today. I'll continue to try my best. So families keep pushing it, not really recognizing how much of an impact they are having on their kids. There are a lot of complicated social dynamics that create vulnerability to bullying, exclusion, or rejection for teenagers as well. So, to go back to social media, people are more aware of what other people are doing now than they ever have been before. So, teens are seeing when their friends are hanging out without them. Teens are seeing if someone says something badly about them. You used to be able to come home from school, put your phone down, come home from school, put your backpack down, not think about anything until the next day. But now children are online all day thinking about what's going on with other people, thinking about what's going on in school. And this creates a lot of complicated social dynamics. So kids are getting very vulnerable with the bullying, with the exclusion, and with the rejection. And that can often lead to a lot of depressive thoughts, a lot of negative thoughts in general, that in turn create suicidal ideation, suicidal behaviors, self-harm. A huge risk factor that I see all the time, I would say in 95% of patients that step through the door of my office. Many teenagers do not get enough sleep. This leads to increased stress in the day and exhaustion throughout the day. So these teenagers are staying up until 2 a.m. and they are online, on a screen, doing whatever it is until 2 a.m. and then they have to wake up for school at 6 a.m. So then they're going off of 4 hours of school, going into a stressful situation, school, and they're exhausted throughout the day. They are falling asleep in class, and they come home from school then that day, they take a 3-hour nap, and then they're waking up at 6 p.m. and they can't sleep again until 2 p.m. So it's at 2 a.m., I'm sorry. So it's just this vicious cycle that teenagers can get into, and we all know that when you don't get enough sleep, you're stressed, you are exhausted, and everything seems 10 times worse than it actually is. So your body really needs that time to relax. Your body needs that time to de-stress. Your body needs that time to just rest and not have to be in high stress situations. And teens these days are not getting that as much. And that's definitely something that I will implement with my patients. It's one of the first things that we try and do is create a healthy relationship with sleep when they come into my office, so that we can really address that one immediately. That's one of the easier ones to address. There's some extreme circumstances when a child will actually have difficulty falling asleep, but most times if a phone is put down, distractions are taken out of the way, and a parent supports a teen in getting into bed at a decent hour, the teen will then get into a better sleep schedule, and it might not cure the depression, but it will definitely improve some of the symptoms so that the exhaustion is not there. Okay, so who in the adolescent population should be screened for depression? A good basis to go off of is all patients 12 years old and above evaluated or treated for behavioral health conditions as a primary reason for care should be screened for depression. You could also go as far as to say all 12-year-olds, regardless of the reason that they are being treated or evaluated for any kind of medical condition, should be screened just as a precaution for depression. Any patients indicating suicidal ideation during their course of care or any kind of self-harm as their course of care should also be screened for depression. The following question would be, so how do we screen these patients for depression? And that is when we get into the different tools that we use. So we have the PHQ-A and the Columbia Suicide Severity Rating Scale. So the PHQ-A, more commonly known as the PHQ-9, is a depression screener. The PHQ-A is just the PHQ-9, but modified for adolescents. So the PHQ-9 is a 9-item questionnaire used to assess symptoms associated with depression. Use of the tool will help you better understand the frequency, intensity, and impact of functioning on any symptoms your client may be experiencing. So here we have the PHQ-9, and as you can see by the instructions, when giving this to a patient, you want to make sure that they're aware that they are only answering symptoms for the past 2 weeks. So not thinking about last year, not thinking about 6 months ago, we're just thinking about the past 2 weeks. So the first question is, in the past 2 weeks, have you felt down, depressed, irritable, or hopeless? Number 2 is, in the past 2 weeks, have you had little interest or pleasure in doing things? 3, trouble falling asleep, staying asleep, or sleeping too much? 4, poor appetite, weight loss, or overeating? 5, feeling tired or having little energy? 6, feeling bad about yourself or feeling that you are a failure or that you have let your family down? 7, trouble concentrating on things like schoolwork, reading, or watching TV? 8, moving or speaking so slowly that other people could have noticed, or the opposite, being so fidgety or restless that you were moving around a lot more than usual? And 9, thoughts that you would be better off dead or hurting yourself in some way. Now for these, the possible answer choices would be not at all, which is worth 0 points, several days, which is worth 1 point, more than half the days, which is worth 2 points, and nearly every day, which is worth 3 points. Once you are completed with these first 9 questions, you add up the points from this section, and that will be your severity score. And we'll talk a little bit about the different rankings of the scores in a second, but to complete this questionnaire, the next question would be, in the past year, have you felt depressed or sad most days, even if you felt okay sometimes? This would be yes or no. And then we want to talk about how their mental health issues are impacting the functionality of their life. So if you're experiencing any of the problems on this form, how difficult have these problems made it for you to do your work, take care of things at home, or get along with other people? Not difficult at all, somewhat difficult, very difficult, and extremely difficult. And this will vary from patient to patient. Some patients can be struggling with depression at a drastic rate and be able to still function on a daily basis perfectly fine. For some people, it's completely debilitating, and this will be extremely difficult for them. The 2 questions that we really want to keep an eye on when screening for any kind of suicidal ideation is, has there been a time in the past month when you have had a serious thought of ending your life? And have you ever in your whole life tried to kill yourself or made a suicide attempt? So previous suicide attempts are very high risk factors for patients with depression, and that's why we want to be aware of that. When completing the PHQA, these are some things that we just want to think about. So sitting side by side with the client, using a paper form rather than virtual, so not having them look at a screen, having them look at this physical paper when filling it out. Reading the questions out loud to clients, so really making sure that they understand what we're doing. And then making sure that explanations are given to the patients when they don't understand the question, and try and be conversational throughout the form. So if they don't really seem like one of these questions is clicking with them, if they have a question about one of the specific questions, a scenario, really making sure that you're taking the time to go through and explain each and every aspect so that the questionnaire can be as accurate as possible. So now we are talking about scoring the PHQA. So things to look out for when scoring, question number 9 and number 12. So like I mentioned before, number 9 is thoughts that you'd be better off dead or hurting yourself in some way. That is an automatic concern. That's an automatic, we're going to have to write a safety plan. That's an automatic, we got to talk to your parents about this and make sure that we are putting things in place to make sure that you are safe. And then, has there been a time in the past month when you have had serious thoughts about ending your life? So if a child answers yes to this, then that's cause for concern and things that we will have to address later on, which I will show you. And PHQ-9 scoring depression severity. So if a child is scoring between 5 and 9, mild, 10 through 14, moderate, 15 through 19, moderately severe, 20 through 27, severe. So for the mild depression, scores 5 through 9, I would say use your best judgment as a social worker. So a lot of the times symptoms will be consistent that come up on here with maybe an anxiety diagnosis. So if they score mild, then trying to make sure that what they are experiencing is actually a depression diagnosis. We can look again at the questions that they will be asked. But things like having trouble concentrating, irritability, poor appetite, trouble sleeping, those are all things that could also be consistent with another diagnosis. So we want to make sure that if they're scoring a little bit lower on this PHQ-9 score, that the actual diagnosis would be depression. If they're getting up here into the mid-teens, higher teens, definitely the 20s, that's consistent with a depression diagnosis. So, like I said, using your best judgment as a social worker. So here are the next steps that we would address if a client screens positive for number 9 or number 12 on the PHQ-9, and you would then continue on to complete the Columbia Suicide Severity Rating Scale, the CSSRS. So the CSSRS is a validated and reliable instrument that can both screen and assess levels of suicidal ideation and intensity, as well as behaviors related to suicide and non-suicidal self-injury. So here is a picture of what this CSSRS looks like. So it's a unique suicide risk assessment tool that supports suicide risk assessment through a series of simple, plain language questions that anyone can ask. So as we talked about with the PHQ-9, we want to make sure that patients are able to fully understand the questions that are being asked of them. So the first would be, have you wished you were dead or wished you could go to sleep and not wake up? The second, have you actually had thoughts about killing yourself? Third, have you had thoughts about how you might do this? Fourth, have you had the intention of acting on these thoughts or of killing yourself as opposed to having the thoughts but you definitely would not act on them? Fifth, have you started to work out or worked out the details on how to kill yourself? Do you intend to carry out this plan? And then number 6, have you ever done anything, started to do anything, or prepared to do anything to end your life? So the way that this works is if number 2 is answered yes, then you go and ask questions 3, 4, 5. But no matter what, you will always ask number 6, and you will always start with questions 1 and 2. Oftentimes, some people are concerned about asking a patient about suicidal thoughts, but it is proven with research that asking if a patient has ever had suicidal thoughts will not trigger suicidal thoughts in the patient if they are not already there. Another thing that we want to keep in mind when completing the Columbia Suicide Severity Rating Scale is the time frame in which the patients are aware they are asking these questions, or these questions are being asked is applied to. So as you can see here, lifetime or past 3 months, and then here, past month. So I personally see my clients weekly, bi-weekly, never more than monthly. So I will phrase it, since the last time I saw you, have you wished you were dead or wished you could go to sleep and not wake up? If this is the first time you're meeting a client, if this is not a client you frequently see, if this is more of a crisis intervention situation, making sure that you are framing the question to say, in the past month, have you wished you were dead or wished you could go to sleep and not wake up? So then going over to question 6, this is when we want to be aware of the lifetime in the past 3 months. So saying, in your lifetime, have you ever done anything, started to do anything, prepared to do anything to end your life? And then if they say yes about lifetime, thinking about the past 3 months. In the past 3 months, have you done anything, started to do anything, or prepared to do anything to end your life? And again, this is very important to think about because we know that a previous suicide attempt is always a risk factor for current suicidal thoughts. So here we are going to talk about the CSSRS directions. So what we will classify two different kinds of questions. The first is the intensity items, and the second is the behavior items. So intensity items are questions 1 through 5. The behavior item would be question 6, which you can see again here when we come back here. So questions 1, 2, 3, 4, and 5 would be behavior, and then 6 would be the intensity. So coming here, we are going to first ask items 1 and 2. If no is answered for both 1 and 2, you ask item 6. And if no is answered for item 6, you're done with the CSSRS. If there's no to all questions on the CSSRS, there's no concern. The next option would be ask items 1 and 2, and then ask item 6. And if yes is said to number 6, then you ask the behavior items. So then you would be done with the CSSRS. So the next would be ask items 1 and 2. If yes to 1 or 2, then we ask the intensity items. If yes to number 2, ask items 3, 4, and 5, and then ask item 6, and then you would be completed with the CSSRS. Coming back here for the next option, you ask the intensity items, and if no to number 2, you can skip over 3, 4, and 5 and just ask item 6. And then, like we said before, if yes, then you must go through the behavior items. If no, you are done with the CSSRS. If you ask items 3, 4, and 5, you must ask item 6 every single time. And then once that is completed, you are done with the CSSRS. So this chart can be a little bit overwhelming to look at in terms of the order that everything needs to be asked in when you ask what, but the CSSRS does a pretty good job at explaining here exactly what needs to be done. So once you complete 1 and 2, which you will do every single time regardless, it tells you when you would need to go answer 3, 4, 5, and 6, and if it is no, that you can just skip to number 6. So these are the levels of ideation that we will be seeing anytime that we give the CSSRS. So we start with low risk and then go to moderate risk and then high risk. So the first level would be wishing to not be living. I would never hurt myself in any way, but I think about what it would be like if I did not wake up is a great example. Sometimes I'll have patients say, I want to go to sleep and not wake up. Sometimes I have patients say, it just feels like too much and I don't want to deal with it anymore. So this is anything that is non-specific. This is nothing that is with the specific intent of committing suicide, but rather just wishing to not be here, wishing to not have to deal with these very intense emotions. The next would be if something happened to make me not living, it would be okay. So we get a little bit more into the suicidal thought. So this would include non-specific active thoughts without method, plan, or intent. I think about killing myself, or I should just kill myself. So this is nothing about intent. This is nothing with the thoughts of this is how I would do it, this is when I would do it, this is where I would do it. It is just a very generalized thought where the specifics have not been thought out yet of I think about killing myself. Nothing further, no elaborated thoughts from there. The third would be active thoughts with idea of methods, no plan, intent for action. So an example of this would be, I have sometimes thoughts about overdosing, but would never actually do it, or thought about how I would do it. So maybe the idea of a method is there, whatever that method might be, but the patient has not gotten any farther in that thought to think about logistics, to think about specifics on how they would follow through with that thought. 4 would be active thoughts with some intent for action, yet no plan for action. So I sometimes think I could overdose and just wish I could do it, but I would never actually do it or think anything about it. So these are thoughts of, I wish I could do it, I want to do it, but I can't. The thought is there, the thought is constantly there. And then we get to fifth, which is the highest risk, and these are active thoughts with plan and intent. So I've had enough, and I think about overdosing and getting the pills out of the cabinet when my mom's not home. Or most days when I walk out the door to go to school, I think about stepping off the curb into traffic, and I feel like I want to do it. So as this says, this is a thought with plan and intent. So this is, I've thought about how I would do this, I want to do it, I might follow through on it at some point. So as you can see, the higher we get in these numbers, the higher the risk it is going to be. So the ideation intensity scale. The ideation scale is to be completed if a client answers yes to any of the questions on the CSSRS. You add up the numbers indicated for the answers given by the client, and the higher the number, the higher the risk level. So when we look at the CSSRS, if any 6 of these is answered yes, is when we will do the ideation intensity scale. So the first step would be the frequency. How many times have you had these thoughts? Less than once a week, 2 to 5 times a week, daily or almost daily, many times a day. As you can see, the higher the number gets, the higher the risk is. And therefore, at the end, when we add all of these up, the higher the number, the higher the risk level. When was the last time you had these thoughts? Within 24 hours, within 48 hours, more than 2 days, but within the past month, more than 1 month, but within the past year, more than 1 year. So as you can see, these numbers are switched around, but the higher number is still the most concerning thought. Duration. When you have these thoughts, how long do they last? 1, a few seconds, minutes. 2, less than 1 hour. 3, 1 to 4 hours a day. 4, 4 to 8 hours a day. 5, more than 8 hours a day. So this section is really great for getting a grasp on how much time is your client spending having these thoughts, thinking about these things. So now we are going to do a check-in question. What is the risk of suicide in a teenager with a history of self-harm? So A, no increased risk of suicide. B, slightly increased risk of suicide. C, moderately increased risk of suicide. Or D, highly increased risk of suicide. And I will give you guys about 30 seconds to think of your answer, use what we've learned so far to come up with your best guess. Okay, and the answer is D, highly increased risk of suicide. So research has shown that individuals who engage in self-harm are at a significantly higher risk for suicide than those who do not. So therefore, it is important for caregivers and healthcare professionals to take self-harm seriously and to provide appropriate interventions and support to reduce the risk of suicide. So, if a child discloses to you in a conversation that they are cutting themselves, if they are burning themselves, if they are punching themselves, unfortunately, children can get very creative in their forms of self-harm. If they disclose any of these to you, then you know that they are naturally at a higher risk of suicide. Especially important to keep in mind if their self-harm practice is practice for suicidal thought. So by that, I mean, if the way that they personally self-harm is by cutting their arms, and they have previously had a suicidal thought of, I would kill myself by cutting my arms or cutting my wrists, then that is an even higher risk level. That's something that is cause for concern because their self-harm practice is dangerously close to the way that they have idealized their suicidal attempt in their mind. So what is the difference between suicidal behavior and non-suicidal self-injury? So the key difference is the motivation behind the behavior. Suicidal behavior is any action that could cause the person to die. So if they are doing that behavior with the intent or any thought, even if it's a small thought of maybe this will make me die, that is considered a suicidal behavior. A non-suicidal self-injury, NSSI, would be any kind of behavior where there is 0% of the thought of this is going to make me die. The behavior is only being done to bring pain to the person or to try and bring feeling to the person. And we'll talk a little bit more later on about the reasons that people would engage in NSSI, but there's no thought of this is going to cause me to die. So here are some examples of what a suicidal behavior would look like versus what a non-suicidal self-injury would look like. So we will start here with an example of suicidal behavior. So a 16-year-old had a fight with her boyfriend. Following the fight, she felt like she wanted to die and remembered the pain medication her mom kept in the bathroom. She went home and brought all of the medication she could find her bedroom. However, before she took the medications, she quickly stopped and changed her mind. So the reason that this is suicidal behavior, even though she stopped right before, was because when she was collecting those medications and she brought them all into her bedroom, she had the intent to kill herself. She had the thought of, I want to die. And that's what caused her to engage in that behavior. So then we come over to the example of non-suicidal self-injury. A 14-year-old reported feeling numb and wanting to experience feelings again. She stated she did not care if these were positive or negative feelings. The girl used her kitchen knife to make superficial cuts on her forearms with the intent to feel pain again, but made the cuts deeper than intended and ended up having to go to the emergency room when her mom came home and found her bleeding. She was then admitted into a psychiatric ward. Again, although this went a step farther than the girl intended it to, we have to look at the intent. The intent was to feel pain again. The result was because of an accident that she had to go to the emergency room. So this would be an example of non-suicidal self-injury because there was no intent to end her life. So now we will go into risk factors and protective factors for suicidal behavior or non-suicidal self-injury. So risk factors are factors that may place individuals at a greater potential for suicide, risks, or attempt. And then protective factors are factors that may protect an individual from a suicide attempt. Reducing risk is not the same as adding protective factors. Both must be done. So we must implement the protective factors while also taking away risk factors. Risk factors are about taking away, protective factors are about putting in. So here are some common risk factors. Access to guns, family member who committed suicide and completed suicide, history of purposely hurting themselves, so history of engaging in non-suicidal self-injury, as we said before, that drastically increases your chances of having suicidal thoughts, history of being neglected or abused, or history of problem contacts via social media. So these are all things that we would want to take out of the client's life. So we would want to remove their access to guns. We would want to remove their access to the social media. We would want to remove them from that situation where they're being neglected or abused. We would want to work on their coping skills to make sure that they are not engaging in non-suicidal self-injury, so we are removing the NSSI. So then coming over to common protective factors. These are things that we want to do more of. So increasing time spent with loved ones, keeping a regular routine, being surrounded by supportive caregivers, or taking prescribed medication and participating in therapy. So we know that social interaction drastically helps individuals with depression. So increasing time spent with loved ones, keeping a regular routine. So waking up, going to school, coming home, doing an enjoyed activity, doing your homework, eating a good dinner, getting that sleep. That would be an example of a positive regular routine that we want these teens to be able to continue to do. Adding in support from caregivers. So also sometimes working with the patient's parents in the best ways that they can be supportive, guiding them to be able to be as helpful as they possibly can be. And then next, adding in medication. Sometimes medication can, in a lot of cases, really, really help a teen. Participating in therapy, that also has a huge impact on teens. So those two utilized cohesively together, there can be some very drastic changes and improvements through that. So the next important aspect of treating patients with suicidal ideation or non-suicidal self-harm is creating a safety plan. And when we use a safety plan, we do want to think about the risk factors and protective factors that we previously discussed, but really getting into what is a safety plan. A safety plan is a prioritized written list of coping strategies and sources of support patients can use who have been deemed to be at high risk for suicide. Patients can use these strategies before or during a crisis. The plan is brief, and it is in the patient's own words, and it is easy to read. So this is something that if a patient starts to notice some of those unpleasant, uncomfortable thoughts coming on, they can pull this out and look at, okay, what are some risk factors I need to get away from right now? What are some protective factors that I can really lean on? What are some of my positive coping mechanisms? I would always recommend making sure that there is mental health care professionals on the safety plan that the patient can reach out to if needed. So whether that be 911, whether that be their therapist or the suicide hotline, making sure that all of that information is on there, and then identified supports. So someone that the patient can talk to immediately, a family member, a friend, a trusted adult, someone that can get them to a guaranteed safe environment if needed. And then who should have a safety plan? Any patient who has a suicidal crisis should have a comprehensive suicide risk assessment. The clinician should then collaborate with the patient on developing a safety plan. So if a patient screens positive for those questions 9 or 12 in the PHQA, as we previously discussed, or if there's any cause for concern from the CSSRS, in any 6 of those questions, if any of those are answered yes, we should immediately create a safety plan. So how to create a safety plan? A safety plan has 6 steps to it. So the first, identify warning signs. So warning signs could be a patient saying, I start to have the urge to isolate alone in my room, or I typically start to have these suicidal thoughts after I'm being criticized by my parents, or when I spend over 3 hours a day on my phone is typically when these thoughts start to come up. So assisting the patient in identifying the warning signs so that when the warning sign happens, they know, okay, this is typically a trigger for me. Number 2, individual coping skills to use. So these are going to be very different for everybody. Some common ones would be exercising, listening to music, reading, talking to a loved one, writing, drawing. Anything that can get that emotion out in a safe and helpful way is going to be a coping skill. But like I said, these are highly individualized. So for all patients, it's going to be different. Just make sure you're supporting the patient and really trying to figure out what's going to work best for them. A lot of kids will say, I don't have any coping skills. And this would be a time where you kind of go through their day, try and pick out some things that make them feel good. So maybe they journal before bed and kind of point out that's a coping skill because that's something that improves your mood, that gives you a release in a healthy way. Maybe it's baking. That's a positive way to spend your time. You're baking, you're doing an enjoyed activity. So even if there's pushback when a kid says, I don't have any coping skills, going through their day and trying to pick some out for them and help them identify those, because they might have coping skills that they don't even personally understand is a coping skill. 3, social connections, people and places for the patient to contact to help distract them. So not only help distract them, but number 4, family or friends who can help resolve a crisis. So number 3 would be social connections that just make them feel connected to other people, make them feel like they have someone to talk to. Again, sometimes a patient might not want to talk about themselves, but maybe it's reaching out to a friend and saying, hey, how's your day? And when their friend is talking about their day, that kind of takes the attention off of their own emotions for them for a second and gives them the opportunity to think about something else. Maybe there's a specific place that the patient can go to that makes them feel better. So maybe once they go into the gym, they kind of get that clear mind, they get their workout done, and they feel better afterwards. So helping them identify those, but then making sure that they also know what family or friends they can call to help resolve a crisis. So if there is an immediate safety risk, if they feel like they cannot keep themselves safe, they can reach out to these family members or friends preferably being over the age of 18, so that there is some adult involved that can get them to a safe place, whether that be an ER if necessary, if the patient is high risk, or creating a safe environment for at home or wherever they may be, if it's a lower risk or medium risk situation. Helping them identify professionals to contact. So this is going to vary based on the setting that you are seeing a patient in. If you are a therapist, you might not be open for contact 24/7. So while making sure that they are aware of how to schedule an appointment with you, making sure that they know how to get in touch with your office if they need to make an appointment for that week, they also have someone that they can call in an emergency. So that might be 911, someone that can keep them safe, get them to an ER. That might be the suicide hotline. That might be a crisis center close by to where they're living, making sure that they're aware of all of those. The suicide risk hotline recently changed to 988, so you are now able to contact them a little bit smoother than previously when they had that longer number. So 988 is a number that I really make sure that all of my patients are aware of, make sure that they know that they can call this number, talk to them. They can also text and have that supportive conversation, make sure that there is a trained professional that they can talk to. So giving them all of those options. Number 6, restricting access to lethal means. So any patient that has ever had any kind of suicidal thought needs to have restricted access to lethal means. And this covers a variety of things. This could be knives in the kitchen. This could be medicine in the household. This could be any kind of ropes or anything that could be used for a child to use to hang themselves. This is any kind of firearms in the household. So any kind of item that could be considered a lethal mean, the patient has restricted access to. And it's very important that when you create the safety plan, because in our case we are talking about teens, that their parent is aware of all of these 6 steps. I will always make sure that the parent has a copy of the safety plan. So this is something that they are on the same page of. If the child is in crisis, they can pull this out and know exactly what to do. So these are some tips that I like to use when creating the safety plan with the client, and some of these are similar to when we were talking about the PHQA and the CSSRS, but the first would be sitting side by side with the client. So sitting with them in a supportive way, making sure that they know that you're there, filling this out with them every step of the way, supporting them every step of the way. Using a paper form rather than a virtual, so not doing it on your computer, but printing it out, handing it to them, and letting them write it in, which goes into the next one, allowing the client to write it out on their own. So you're not writing it out. You really want to make sure that the client writes it out so that it's in their own words, that it's understandable for them, because when they are in crisis, you want it to be easy to read. You want them to fully understand what they wrote. You want them to be completely on the same page in that crisis as they are when they are thinking with a clear mind. And you also want to address any barriers that might be in the way on the safety plan. So if a patient is saying that their biggest coping skill is going on a long walk, but you're living in a cold climate in January, you might want to talk about, you know what, that's a great coping skill to keep in mind 6 months from now. Is it realistic for you to be able to go on a walk right now in the middle of January? Because you then, in that moment, can come up with a new coping skill rather than if they're in a crisis and they look at their safety plan and one of their only coping skills is going on a walk and it's 0 degrees out. So addressing any barriers in that situation. This could also mean making sure that they have access to all of the professionals and the adults that they wrote down on there. So if they're writing down a trusted adult who is a teacher, what if it's the weekend and you don't have access to that teacher? Just making sure that you have support regardless of what the situation might be. So that is what addressing any barriers will mean. Here we have our treatment planning overview for any patients that you might see as a social worker with an SSI or suicidal ideation. So for low-risk patients with no suicidal ideation, so these are no thoughts of harming themselves, of not wanting to be here, anything like that, you will screen in the future when clinically indicated. So if a thought does come up, if a patient does say something that is cause for concern, you will always screen then. Sometimes it will even be just every appointment, just at the beginning of the appointment, saying, hey, have you had any suicidal thoughts since the last time I saw you? Have you engaged in any self-harm since the last time I saw you? So whatever process is appropriate for your agency, for your hospital, whatever that might be, screening in the future when clinically indicated, and also using your best professional judgment in that situation. Monitoring risk factors. So as we mentioned previously, if this is a child who has frequently been bullied, if this is a child who is LGBTQ+, if this is a child that comes from a past of neglect or abuse, monitoring those risk factors to make sure there is nothing that triggers any kind of suicidal thought in that patient. And then treating referral diagnosis. So if this is a patient that is referred to you for any kind of mental health diagnosis, making sure that you are still treating that referral diagnosis and remembering that that could still be depression. Every patient that is referred to you with depression is not going to have a non-suicidal self-injury habit or have suicidal ideation. So that might be depression, that might be anxiety, ADHD, whatever it might be, making sure that after you're completing this assessment, treating referral diagnosis. Then comes low risk treatment planning for passive suicidal ideation. So this would be creating a safety plan, as we just discussed, going through that safety plan, making sure it's thorough, making sure there's no barriers in the way, making sure that the patient is on the same page, and so is their caregiver. Since we are talking about teens here, all of them are minors. And then follow-up plan. This would ideally mean that a patient is coming to see you again within 2 weeks. So you are able to continue their treatment, continue to check up on them, continue to make sure that they are getting the attention that they need, the treatment that they need, and there is progress being made. Moderate risk would be, of course, making that safety plan, and then, of course, having a follow-up plan. So within 1 to 2 weeks. Once we get into the moderate risk range, I'd highly encourage making sure that you are seeing that patient weekly so that you can track their progress, track any issues that they might be having in their treatment, any worsening thoughts that they might be having when it comes to the suicidal thoughts or the self-harm. High risk would be a referral to an emergency department so that in the emergency department, they can assess to gauge the client's ability to keep themselves safe. If they are not admitted, emphasize the safety plan and make sure that they follow up with you. So if there is any cause for concern that a patient is not able to keep themselves safe at home, This would mean that they should go to the emergency room where they can be evaluated, and they can either be admitted for some kind of inpatient treatment. They might be referred to some kind of outpatient treatment. But if a patient is high risk, meaning they have intent to follow through on any kind of suicidal ideation, they need to go to the emergency room to keep themselves safe. And we are going to wrap things up with a final check-in question. So, when is a safety plan required when treating a depressed patient as a social worker? A, only when the patient expresses suicidal thoughts, suicidal ideation, or self-harm. B, only when the patient has a history of suicidal behavior. C, whenever a patient is diagnosed with depression. D, whenever the social worker deems it appropriate. And I'll give you guys a second to think about this. Okay. So the correct answer is A, only when the patient suppresses suicidal thoughts, suicidal intent, or self-harm. A safety plan can help a patient with depression to help themselves identify warning signs of worsening depression, but it is not required. The safety plan is a crucial component of treatment for if a patient specifically identifies suicidal ideation or self-harm. So this is a situation where we really want to look at one of the key words in the question, which here would be required. So when is a safety plan required? And that would be only required when the patient expresses suicidal thoughts, suicidal intent, or self-harm. You can use it at other times, but the time it would be required would be when this patient expresses the suicidal thoughts, intent, or self-harm. You may think that a safety plan might be helpful for a patient in other situations, and that's great. Now we know how to use a safety plan. Now we know how to fill out a safety plan. So I would always encourage a social worker to use their best judgment. And if they think that a safety plan would still be helpful, even if it's not a required situation, go for it. Safety plans can be a great resource for patients just to have to reference when they're at home. They're obviously not in a social worker's office 24/7, so it can be great for them. So thank you guys so much for tuning in today for the CE on identifying risk factors in suicidal ideation or self-harm, and creating a safety plan, and really utilizing these tools to identify a patient's greatest risks, identify how to keep a patient safe. If you have any questions, or if you want to find out more about Agents of Change, please email us at agentsofchangeprep@gmail.com, or go to our website, agentsofchangeprep.com. On our website, you can find a lot of great resources, both paid and free, to become the best social worker that you can be.
I hope you enjoyed this continuing education course from Agents of Change. Want to earn your CE credits for this course? Visit agentsofchangetraining.com or the link in the description to purchase the course and take the post-test. If you're looking for more CEs, check out our unlimited plan. You will get unlimited access to 150 plus ASWB and NBCC approved continuing education courses for one low annual fee. We're always adding new courses. Did I mention we also have 5 free CE credits available too? Check it out at agentsofchangetraining.com.